This is okay?
Yes, that's perfect.
Right. So, well, thanks for the invitation again. It's a pleasure to tell you a little bit about my role and our role in World Child Cancer, especially World Child Cancer the Netherlands. And in Dutch, I thought to give you both the Dutch and the English name. Our Prinses Maxima Centrum for Kinderoncologie, in other words, the Prinses Maxima Center for Pediatric Oncology, and what we do together. So I'm a pediatric oncologist, so I'm a pediatrician, but now I, in a way, limit myself to children with cancer, although they have many complications, sometimes by the disease and mainly by our treatments, that is general pediatrics. And I'm one of the directors of Princess Maxima Center, and I will explain you a little bit. I'm director of the Department of Academy and Outreach. The Princess Maxima Center is not an academic institution, so I am a professor, but appointed at Amsterdam University Medical Center, especially actually quite close, probably 300 meters from here, in the VU University Medical Center here in Amsterdam, where we have centralized all the care for adults with cancer in Amsterdam, but the Princess Maxima Center is the Dutch National Center for all children with cancer. So we have an outreach program, and because we needed some or a lot of financial support, we also initiated World Child Cancer. I will first go tell you a little bit about the Princess Maxima Center and why this emerged. And it has, of course, many stories. But one of it is that, of course, we realized as pediatric oncologists already quite some time ago that if you really want to be excellent in something, you must practice a lot. And that goes for sports, I guess. I'm also a tennis player. I always tell my students, you can never be a great tennis player like Murray for you or Federer. We have a few Dutch good players, we have them. But you have to practice a lot. And that also is true in healthcare. And this is one of the many documents that supports that. This is from our Dutch Ministry of Health. And they showed that if you have a higher volume of, let's say, a surgical procedure, the complication rate goes down. And quite arbitrarily, we said back in 2005 or 2006, well, we said in our oncology service, that means we need 20 cases per year per team. And that's not what we had. We had 3 or 4 patients, cases is patients here, per year per team. But when we brought it together, it became, for most diseases, about 20 cases per year per team or more. And bringing that together, the 7 centers we had in the past made the Princess Maxima Center to become a reality. And we raised a lot of money, and we convinced the insurance companies to pay. And then we could build this building. This is not a drawing, it's a real picture. It's from the garden. This is the hospital area. I'm not sure, do you see my pointer or not really? Maybe not, and then I'll tell you. So on the left, you see the hospital area, and on the right, you see the research building, but it also includes our pharmacy and also our parking lot. And even while we brought everything together, we still are small, meaning we have 87 hospital beds, we have 35 daycare beds, but it's very complex care. So at the end, we have much more than 1,200 employees. It's really already 1,400 now. It's not only a hospital, it's also a big research center connected to it. And we have now 400 scientists working in that research building only on childhood cancer. And that really is a lot. So this is the picture showing you that we brought everything together to Utrecht. It's not known to all of us. It's in the very heart of our country. It's a nice city, actually. I can recommend you to visit it. It's really close to Amsterdam. But these arrows that you see, they also should go back, because we also have set up a shared care model, because not everything has to be done centrally. So our model is what is complex we do centrally in the Princess Máxima Center. What can be done closer to home, we do it in the former childhood cancer centers, such as in Groningen in the north, or in Rotterdam, in Amsterdam, or in Nijmegen. So we are a small children's cancer center, and to be honest, on our own, we could not make it. So we really needed a very good neighbor, and that became the Wilhelmina Children's Hospital, which is part of the University Medical Center Utrecht in Utrecht. And that is one of our bigger university medical centers. So this is a very important collaboration here. And then outreach. And let's go back to my first trip to Kenya already now 13 years ago. And actually my former boss told me, I think we can help these children with cancer there as well. Why don't you go have a look? And I was appointed professor 2 years before that. And I thought that was a good idea. I go there and I went to Eldoret, Kenya, which is in the eastern part. And I saw a children's hospital, which was really so much worse than what we had in the Netherlands. It was sort of heartbreaking. The children were, 2 or 3 of them were in one bed, let alone the parents, because each child has a parent joining them. They were somewhere in that bed as well, or on the floor. They were close to the cemetery. It was really terrible. At the same time, there was 2 pediatricians who were very dedicated. There was an American program, mainly because of HIV or AIDS, but they also supported drugs to treat children with cancer. So I also saw some possibilities, and I thought, let's try to help the hospital by starting a collaboration between, at that time, the hospital in Amsterdam and the hospital in Eldoret, Kenya. And when we started working on the Princess Máxima Center, so then I thought, okay, so we should have an outreach program, and some call it global health, global child health, and then international outreach program. And of course, the Princess Máxima Center, because it's a really big center, and it's now to be honest, it's the biggest center worldwide in the developed countries. There are bigger centers in developing countries, but they don't treat all their patients. But we are really a big center. And I thought we should have an outreach program. And I also realized quite some years ago, and that's when I met Gordon, that we would need a foundation supporting us. And I asked some Dutch foundations, and they were not interested to mainly care for children with cancer abroad. I asked the Princess Máxima Center itself, but they were so involved in their own business, and fair enough. So that's when I learned about World Child Cancer, and I initiated World Child Cancer in the Netherlands. And that was on, I would think, a symbolic day, because February 15 is World Child Cancer Day. And that is now 4.5 years ago. And I was also preparing the academy business, or the academy projects. And the academy is our training and education program. And I thought, well, outreach is mainly about transferring our knowledge and skills. So this very much fits to this academy. And so we made the department Academy and Outreach. And of course, to be honest, that was also convenient to me, because I could be the director of both projects at the same time, or programs. And this is, of course, some children at that time in Kenya, and this is a child in a hospital in Jakarta, Indonesia. And you may know that we have a lot of history with Indonesia. And that's, I guess, one of the reasons why we also collaborate with a hospital and soon hospitals in Indonesia. So outreach, why? Well, there's really a huge gap in survival rates between high and low and middle income countries. And the gap is huge. I will show you in a minute. And you must, and I guess you know it, but we don't always realize it. Most children live in low and middle income countries. And I think these two facts, they made the World Health Organization to come up with a global initiative some years ago now, to actually say, in a way, we really must improve chances of cure for children in these poorer countries as well. And we in our center, and there are certainly also centers in the UK, we have the knowledge and the expertise to help closing the gap, which is not acceptable. So this is some data on what we see per year globally. And in the Netherlands, we only have 600 children with cancer diagnosed each year. In the UK, it should be about 1,800. In the USA, 16,000. In Kenya, where we are active in, it's 4,000. In Indonesia, because it's a huge country, of course, 10,000. So globally, there are at least 400,000 children with cancer each year. The far majority of them live in these low and middle income countries. So that is basic facts. If you look at survival rates, we in the Western world, as we sometimes call it, or well, whatever you want to call it, we at the moment have about 70 to 80% survival on the long term. So that's really high. It's not 100% what we aim for, but it's really high. In the low and middle income countries, it's really much less. It's 10 to 20%. And the reality is that most children even don't make it to a diagnosis. They are not even diagnosed, and they simply die without having had the chance to be cured by a treatment. But even if they had the treatment, most die. So this is a big gap. I hope you agree. So World Child Cancer Global, and I have to be careful because Gordon is here, but and there's another, I just learned colleague from World Child Cancer, but I think I cited well. So the vision here is, oh, that's a typo. The vision here is that there should be a world where every child with cancer has equal access to treatment and care. And the mission is to improve diagnosis, treatment, and support for children with cancer and their families in low and middle income countries around the world. And as a Dutch World Child Cancer, the Dutch are always a little bit stubborn. We said, well, in a way, we also have the mission that we want to achieve this for the high income countries. Why not? We also want to help the care for children in high income countries, knowing that's not perfect yet either. But we are part of a global initiative, and we share this vision and mission and some other approaches. And this, I hope it's up to date. It was made by one of my colleagues, but this is a map, I think, that World Child Cancer UK every now and then updates. So World Child Cancer is now active in at least 13 countries, and you could argue we are active in more countries because of networking. So what we do spreads, of course, in the surrounding regions. But there's many countries where we are active in, many countries in sub-Saharan Africa and in Asia as well. In Dutch, we are active in countries Indonesia, Kenya, Kosovo, which is in Eastern Europe, and in Malawi at this moment. So it's depicted here. At this very moment, we have 4 twinning programs, as we call it, collaborations with hospitals in Eldoret, Kenya, Blantyre, Malawi, Indonesia, and closer to home, but in a very special part of Europe. Some of you may know the history in Pristina, Kosovo. We are expanding to 5 countries, and we are expanding from 4 twinning programs to 7, but that will take some time. I already mentioned this sort of global initiative or a global effort. We are, as World Child Cancer, not the only parties involved. St. Jude's is a very well-known childhood cancer center in Memphis, the USA, has been doing this type of activities already for decades. SIOP is more and more active in the field, and now we get support from World Health Organization, which is important, with this global initiative on childhood cancer. And what they said, let's achieve 60% of cure for the curable types of childhood cancer by 2030. And that is sort of worrying close. We have to work hard. You may wonder, what are these curable types of cancer? So it's acute lymphoblastic leukemia, which is the most frequent childhood cancer, occurring in adults, but much less frequently. Burkitt's lymphoma is a special type of non-Hodgkin's lymphoma. It's also mainly occurring in children and quite rare in adults. Hodgkin's lymphoma, another lymphoma, is also well known in adults. Wilms tumor is a typical childhood cancer. It occurs in the kidney. We also call it nephroblastoma. Blastoma is from very undifferentiated embryonal tissue. And that also goes for the retinoblastomas, which is this very undifferentiated embryonal tissue in the retina, in the eye. And there's one brain tumor in this listing of 6, and that is the low-grade gliomas. To be honest, this cancer is rarely diagnosed in children in low-income countries because they lack MRIs, and you need an MRI to diagnose a brain tumor. So the outreach program of Princess Máxima Center, that is where the activities come from. And we have 2 main types of activities: twinning programs, collaborations between our center and an hospital in a poorer country. And we have research projects, and that is not the fancy research in the laboratory that we tend to do also in our center, but it's research closer to the children and the families living in low and middle income countries. And of course, trying to tackle the problems that they face especially. So we have sort of a core team. Gertjan Kaspers, the pediatric oncologist, she's running the twinning program with Prof.dr. Saskia Moffat is doing a lot of research projects. Natasha is supporting in an administrative way. Martina is a pediatric oncologist running the twinning program with Kosovo. Sanne is involved in money. Tijn has just left us, but is still active in Malawi. This is me. This is Gertjan Kaspers. She is doing fundraising for World Cancer, but also she's coordinating all the programs that Princess Máxima Center has. And Minke is the recently appointed pediatric oncologist, and she's going to run our projects in Nairobi and in Tanzania, in Moshi, Tanzania. That's a new collaboration. A little bit about these twinning programs. This is a picture made when I was there with Gertjan Kaspers in Jakarta. We make work visits, and of course, we recommend treatment for individual patients. We recommend on improving protocols. We advise on infrastructure and organization. But it's not only pediatric oncologists. We are multidisciplinary. So nurses join us, child life specialists join us, sometimes a pathologist or a surgeon, could be a radiotherapist, very much depending on what they need. And of course, mainly we transfer our knowledge and skills. This is really important that you make sure that there are locally applicable protocols for, let's say, the 10 most frequent types of childhood cancer. That may seem to you, I mean, an open door, and of course you have it. But the reality is, whenever I come in a new hospital, they don't have it. They simply don't have it. At least they don't have the up-to-date protocols. They also are far behind how they inform patients and parents. And that's simply, I guess, you know, time, evolution, culture. But we also did not do that 30 years ago or 40 years ago. We just told somebody, okay, you have this and you get this treatment, go for it. But now we learned that we must extensively inform our patients and parents so that they stick to the treatment from the beginning until the very end. We also advise a lot on supportive care. We cause a lot of complications with our treatment, and it's really very, very important to cope with that, and that is what we call supportive care. Dealing with infections, dealing with malnutrition, giving blood transfusions, things like that. It's hard work, but it's also fun. It's really team building as well. This is a picture from 2 years ago. This was the Dutch ambassador, and we will go back this November, and the new Dutch ambassador will join us as well. This is the CEO of our Princess Máxima Center at that time, but now there's another CEO. I'm still there, but the CEOs get replaced. I'm not sure if that's familiar to you, but our new CEO will join us as well. Replaced in the sense that she simply retired. And of course, we try to vlog a lot and to write and to publish on whatever we are doing. One slide on the research project. I'm not sure if there are scientists among you, but you can ask me whatever you wish, feel free. You should be able to deal with most of it. So we have a couple of lines of research, global health related, pharmacokinetics, to me quite interesting, and more general pediatric issues. So, you know, the issue is that in these countries, often a community, parents, they don't realize that childhood cancer occurs. They simply don't realize it. When they think about it, they think it's a curse. And when they think about going to the hospital, they think if you go to the hospital, you have to pay a lot of money and you will die anyway. So this is a really important aspect to deal with pediatric oncology, and that we call that awareness and early referral. When the children go to the hospital, they go too late, and that's really not what you want. I have not included the pictures of the children I have seen also very recently in my recent visit earlier this month, because I thought it was too much for you, but they really come in too late. When they come in, they also not always realize they should complete the treatment, and they will, you know, abandon before the protocolized therapy has been completed, and we call that therapy abandonment. When they are cured, some children are cured, and more children are cured. There's really an issue of stigmatization and a problem to socially reintegrate, and we are working on that. Pharmacokinetics, we are learning that individuals, they deal with drugs differently. We are also learning that it's in part it's influenced by your ethnicity and malnutrition. And I always give the example of the Japanese. They're not, most of them are not able to drink as much alcohol as we Dutch do. They get, how do you call that? They get drunk earlier. And that is because they don't have this enzyme. They frequently don't have this enzyme in a high activity to metabolize ethanol. But we know nowadays that the same goes for drugs. And we are slowly learning that Black children, that they may have a different pharmacokinetic of vincristine, and perhaps also of doxorubicin in relation to malnutrition. And of course, malnourishment is frequent in low-income countries, and it's quite rare in the UK and with us. But this is really important, and what it will lead to is that you don't give the average child the average dose, but that you will recommend an individualized dose. Well, general political aspects, I think you will recognize most of this, and because of time, I will not go into the details of this, but also very important. And to give some faces, the vincristine project, Annick Uitenboog is working on that. Dr. Buzin Minke, Awareness Larissa, Survivorship Jesse, who's actually now twinning with a Kenyan colleague and working in Eldoret, Kenya on this issue. And Saskia is often in Indonesia collaborating with local colleagues. So we are always partnering. We make achievements, and of course not on our own, but we make achievements. Survival rates are going up in Kenya, in Indonesia. For Wilks tumor, for instance, you may remember this kidney tumor. We recently showed that the chances of cure, if you get the modern treatment over there, chances of cure is 60%. We get more and more patients in the hospital. So we are really having more than twofold in a couple of years of patients. We trained a lot of professionals, and the adherence to stick to a treatment protocol is really going up from, let's say, 50% to nearly 100%. So it's really, you know, it's a small step to bridge this gap between 70–80% survival in our countries and the 10–20% survival in the low and middle income countries. But of course, you know, ultimately that's not enough. And even what I show you here is not enough. At the end, we want to cure all children, don't we? It's a simple mission as that. Cure for all children with cancer, and I think I have told Gordon once, but one of my dreams is that in 5 or 10 years we have this charity events, not only in Amsterdam, but also in London, or if you think that's more appropriate, in another center in the UK and in New York, and why not in Nairobi and in another country such as Jakarta or Jakarta, and that we raise a lot of money to improve the chances of cure for all children with cancer, because at the end money does play a role here. But it's not only money; it's also other factors that we must investigate. So in a way, I also urge you to help us. But I'm sure with Gordon being one of your colleagues, I'm sure you are already ambassadors on this project to aim for cure of all children with cancer worldwide. Thank you so much.
Thank you, Gertjan. We will now revert back to remove spotlight. Right, so you've agreed to answer questions, Gertjan. So could I now hand over to our audience to see what questions we have?
Feel free. I always tell there's no wrong questions. I can only give the wrong answers.
Keith, I see your hand up.
Yeah, thanks, Gordon, and thanks, Gertjan. That's a very wide-ranging presentation. I'm very interested in the comparisons, sort of Indonesia, Kenya, Holland, and particularly the rates that you've been able to achieve, presumably by applying the learning. First point is, do you train local doctors to actually effectively take the roles that you have in those centres, or do you actually rely on oncologists coming across from Holland and from other areas? That was the first question. The second one is, are you liaising with any of the London hospitals like Great Ormond Street or Brompton Marsden? Is there any relationship that you have there? So those are my two questions. Thank you.
Yes, thank you so much. About your first question, certainly we do. All of what we do is to, it should be sustainable. And if we visit one of our twinning partner hospitals, we are only there for a couple of days, sometimes a couple of weeks, rarely perhaps longer. But it's all aimed to transfer our knowledge and skills to the local people. And that is indeed the model, of course. And to be honest, I don't hope there's many US colleagues among the audience, but the US, I sometimes see doing that differently. They built their own buildings, and they have their own organization next to their local hospital, and they have their whole team, and that seems to me a duplication. So we really want to sort of assist our colleagues over there, and they should take it over. And in Eldoret, Kenya, where I've been working now for the longest part of my career, it's happening. And in the beginning, I had a couple of calls per week about individual patients, and it's rarely being done anymore. And I think that's a good sign. And we are now collaborating with them at another level, in a way, in more scientifically oriented research projects. So certainly that is our long-term aim, absolutely. We also, in Kenya, we managed to initiate a formal, recognized by the government training program for pediatric oncology. So the pediatricians can now formally become a pediatric oncologist by running their own programs in Eldoret, Kenya. And I'm a visiting professor, but there are many local colleagues involved in the training. And we are going to set up a similar thing for nurses. And to also give credits to World Child Cancer UK, they have supported a similar project in Ghana for the nurses. So that's really what we try to. And then your question about UK centers, I will give you sort of two answers. There's already a couple of UK centers involved in this type of collaborations. I know, personally, I know that Newcastle is doing it, but I'm sure there are other centers doing it, and Gordon may may add them. I'm also active in an international pediatric oncology society, and I have asked all types of centers, also in the UK, can you join? Can you step in? And to be honest, the reply was rather limited. And I guess that's also because we are rich in a way, relatively speaking, but also very busy. And certainly also in the UK, I know that the pediatric oncologists, they really have to deal with a lot of patients with a relatively low number of consultants, as you call it. And for whatever reason, the system in the Netherlands seems to be a little bit more luxurious. So we have more consultants for our numbers of patients than you have in the UK. So I think it's also understandable that there's a limit to what you can do, because of course, you spend part of your time to other patients, not in your own center, right? Yeah. But we are certainly open to it. We have collaborations. I go back to Eldoret, Kenya for a workshop in January, and one of my Swedish colleagues will join us. So we have an international approach, and I'm sure that sooner or later there will also be a colleague from London, one of the London centers, joining us. And I'm not sure why you mentioned Great Ormond Street. I actually trained myself there when I was a fellow in 1998. It was a great time. I learned a lot there. It's a very good center. Yeah.
Thank you.
Can I ask a question? Gordon, can I ask a question?
Gordon's got muted somehow.
I think Gordon was muted,
Yeah,
but I hear you. I see George also wants to ask something, I think.
Yeah. This may be totally off the wall, but in general, I always have an inquiring mind about what you can do to prevent, as well as what you can do to actually treat people after they've acquired illnesses, or whether it's mental health or whatever. I just wondered what, if any research is going on to see why numbers are differential in different countries, whether it's just the basic level of hygiene and so on, or whether there is anything emerging either in those underdeveloped countries or in developed countries that are starting to point to things that we should be building into our societies to actually minimize the numbers of people who actually eventually
children who get
cancer.
It's a good point. So again, two types of answers. So when it is really about childhood cancer, there's not so much of external causes. Also meaning it's extremely difficult, if not impossible, to prevent it. And we don't see major differences in the incidence of childhood cancer among the world. So when you look at Eskimos or Masai Mara people in Kenya, or to the Dutch people, it's essentially the same, with a few examples. And that is the tragic atomic bombs on Japan at that time, the disasters with nuclear plants. But otherwise, hygiene, what you eat, whether the mother smoked during pregnancy, it doesn't play a role. So it's really, I think it's going to be extremely difficult for the next, I don't know, centuries even perhaps to prevent childhood cancer to occur. There is, of course, a couple of things that the children should avoid so that they don't get cancer when they are older. And certainly sunburns is on the list. And again, too much of irradiation. But too much of irradiation is not common if you live normally. I mean, you should fly a lot to get too much irradiation. You should be in the CT scan every 2 weeks or so to get too much irradiation, or you really should live in a very dangerous area, which is uncommon. So it's mainly, I guess, about sunburns, perhaps, that we can prevent melanomas when the children became adults. But for childhood cancer, prevention is certainly not the way to go at the moment, unfortunately.
Thank you.
Yeah, but good point. Is Gordon back?
Gordon, I think you're still on mute.
I think George.
I was talking to myself. That was the problem. Peter, you're also muted.
Okay.
Yes, right. Ask your question, Peter.
Okay. When you go into third world countries, you'll have the people who are going and setting up the facilities in the poorer countries will have the capability to deal with all the cancers that they can deal with in their own country or in their rich own country. When you go to the poorer countries, apart from all the protocols you have to follow, the key one I would suspect is how do we get the greatest good for the least amount of cost and effort? And that I presume would be the ideal. But when you go into these poorer countries, maybe also sort of fair egalitarian attitudes are less well established than probably some of our richer Western countries. Does this present a problem when you go into poorer countries?
Yeah, I hope I understand you. So I think you're asking, I mean, perhaps what should get the most attention in a way in these countries? What is the biggest issue, and where you should put your efforts in and your money in? Yeah. And then perhaps at the moment, childhood cancer is not number one, but there's really a lot of focus already by many parties on malnutrition, on infections, on simple dehydration, and as examples, malaria and tuberculosis and HIV. And there's billions and billions of euros or pounds, whatever you wish, invested in that. And it's improving. That field in children is improving. So less children are dying. You may argue that at this moment we have a setback because of the COVID-19 measures, not so much because of the virus, but because of the measures, unfortunately. But it's improving. While childhood cancer is not really improving. So I think it's worthwhile to invest in childhood cancer, knowing that there's a lot of investment in other areas as well. And what we always see and what we always try to be aware of is that we should not limit ourselves to children with cancer. So when we try to improve things locally, we also try to improve it for the other children with other diseases. And in a way, when we transfer our knowledge, I think that also extends to pediatricians who focus on other areas of diseases. Is that some sort of an answer, or am I not close?
No, I think it is part of the answer, but another part of it was, are you pressurized when you're in these countries to treat certain children rather than others? I mean, I'm sure you get this everywhere because every individual will want to do the best for their child. But how do you cope in a poor country with the pressures that might be different to the pressures you would get in a Western country, for instance? And how do you manage to retain your moral? No, I think that is not that difficult for us because we focus on the public hospitals. So we deal with the big hospitals for the people in the poor countries. So we are hardly involved in the few children who are in public hospitals or who go abroad anyway for treatment. And we don't focus ourselves so much on the individual patient. We focus on our colleagues, and we give our recommendations how to deal with individual patients to our colleagues, and they have to deal with the individual patients. Yeah.
Peter Blaskos, do you have a question?
I do. Yes. Good evening. I've read recently that the huge effort that went into producing the vaccines for COVID might have some applicability towards, I don't know, a vaccine, but some treatment for cancer. Is this just a pipe dream or a hope?
Now, there is research ongoing, certainly, because in a way you can argue that if you get cancer, that our immune system failed, right? Because you can argue that a cancer cell is not a normal cell, and our immune system is supposed to get rid of the abnormal cells, although mainly meant for viruses or bacteria or sometimes a yeast. But you may argue that the immune system also failed to get rid of the initial cancer cells. And there's certainly interesting research on vaccination studies aimed to stimulate the immune system to become active against your own tumor cells. And it seems, but this is relatively early research, that some cancers, it's effective, it can help. It may not be the only solution, but it may be part of a comprehensive solution. In childhood cancer, it's very early on, but that's also because we have quite different types of cancer in children than in adults. We also have low numbers of patients. So globally, you know, it's still a lot to me, more than 400,000 children, but it's actually per country, per type of cancer, it's low numbers. And that is always difficult when you want to investigate a novel treatment in a clinical trial. So I think vaccination studies are going to help us. And some of the techniques we are using with the COVID-19 vaccinations is novel. The messenger RNA vaccinations is novel, and that well, that could help. It could, yeah.
Thank you very much.
Thank you, Gertjan. Jim Tatchell.
Thanks, and thank you, Gertjan, for a really interesting talk. I was just wondering, what can we do? Obviously, one of the main issues that the poorer and developing countries have is lack of money, and that's kind of obvious, and that applies to lots of things. But apart from providing more money, what can we in our relatively comfortable Bishop Stortford do to help, apart from, I guess, putting pressure on any oncologists that we happen to know to join your work? But apart from that, what else can we do?
Yeah, well, I guess many things. I mean, advocacy comes to mind. You know, at the end, if you speak about the injustice in terms of this gap in survival, and in some way or someday you may reach people that are influential locally, because it's also a matter of attention, right? I mean, it's also what you spend for a particular group of patients, in this example, children with a particular type of disease. So advocacy, I would think. What I am observing is that in many situations, the facilities are simply not good enough. So that's not so much knowledge about how you treat a child with cancer, but they need a bigger building with larger rooms, with some space and beds. And well, we built a beautiful childhood cancer center. And I would think that some of the people that were involved could also advise how you build a slightly similar building, but without charging your time efforts. We are starting a project, we call it simply Project Data. So data is really important to know how many children are diagnosed, what types of cancer do they have, what is their outcome, does it matter how they were treated? Well, it's all about data, and that is also about hardware, it's also about software. And there, I guess people can advise as well, and sometimes sponsor in kind, perhaps. So I think there are certainly other ways to help, not only with money. Yeah.
Thank you.
Hey, Colin George.
Yeah, another question. World Child Cancer now obviously has quite a lot of experience of moving into a new country to help, and will have built up a lot of experience in terms of what's worked and what hasn't worked, and what have been the priorities in terms of influencing those particular countries or organizations. And I just wondered if you have actually a research project within World Cancer that tries to capture the learning from all those different examples in a way that might be possible to package almost into some distance learning. So you can't reach everywhere, but there may be a massive learning body of knowledge now from all the experience you had, which can be somehow utilized to stretch your reach even further than it's possible now with the manpower and so on that you have.
No, good point, of course. Well, yes, this is happening to some extent, certainly. So the World Child Cancer, there are 3 World Child Cancer charities, and they have also a program committee, and we meet every now and then, and we exchange experiences. So we learn from each other. So that's one way. In the Netherlands, we have set up a shared care system. I briefly mentioned it. And I think, in the low and middle income countries, they have too many patients in these centers. And I think it's worthwhile for them to also start working on shared care. That's not easy because communication is very important. But we will publish how we have made this model, and then it becomes available to everybody in a way. We publish, for instance, with international colleagues, we publish guidelines how to treat different types of childhood cancer with locally applicable protocols. So that means it's adjusted in intensity. You cannot treat the children as intensive in Malawi as you can in London. That's certainly impossible. They will die from the complications. But we are publishing this, and then it becomes available. I think the example of training programs for nurses and pediatricians to get trained in pediatric oncology is good examples where we really exchange our programs, and we make it available to anyone who wants to work with it. So it's happening. It can also always improve, but I think we are working on it.
Good, thank you.
No Younger.
Yes, you mentioned a database, and I got the impression that you don't have you have to do your own database for childhood cancers. When I was very much involved in designing the UK cancer registry database, or the English one. But the types of cancer you're talking about at adult level are entirely different. Or there's many more types of cancer than there are the ones you mentioned, the leukemia and the lymphoma that you were talking about. And I just wondered whether I mean, I'm sure that the Netherlands has its own cancer registry, because I know most European countries do. Whether you have a problem using theirs because it's not sufficient to do the sort of detail that you would require for the childhood cancers.
Yeah, but that's the issue. So there is basic registry supported by World Child Cancer. I think mainly it's run by what we call NREC software, and that is okay, but it only gives the very basic information. And we need, as pediatric oncologists, we need more detailed information. If a child dies, we must know when does the child die. And was it because of the cancer, or was it because of the complication from the treatment, for instance? And that is the type of detailed information which is not in the current database. And I don't want to suggest that we want to have sort of a World Child Cancer database that we own. The model is that in the countries that we are active in, that they make their own databases, and they run it themselves, and we only advise how to set it up. Ideally, of course, we will learn from it by comparing data and doing scientific research projects on it. But then it's a collaboration that all of them and us agrees upon. Yeah.
Yes, we had to do exactly the same with it was the Eastern region one I was working on we had to add all the detail about the treatments and who did the treatments and when they took place, and
Yeah.
it's entirely different. It was adding another dimension to it.
Yeah.
But we were dealing with different sorts of numbers. We were doing sort of 40,000. Well, England-wide, it's 400,000 new cases a year.
I can imagine, yes. Yeah, it's totally different numbers, right?
It is, yeah.
Yeah. Now, childhood cancer is about 1% or less of all the cancers in human beings. Yeah. It's in a way a rare disease, fortunately.
It is, yes, yeah.
Yeah.
Jim Tatchell asked, what can we do to help? Just a matter of interest, Gertjan, one of our members, Robert Muir, constructs medical facilities, buildings in the developing world. He leads a charity to do that. And we're working with Robert to come up with a proposal for a new hospital wing in Malawi. And I've got this vision. We've got World Child Cancer in Denver, Amsterdam, and London.
Yeah.
Matching these offices with Rotary clubs in these same countries and Malawi. There may be some, and then we could maybe tap into some global Rotary funds as well.
Yeah, I think it's a great idea. It was a little bit complicated, the idea, at a certain moment, because we had some problems in our collaboration with the hospital in Blantyre. But fortunately, that has been restored. And that makes it easier for the Princess Máxima Center and Gertjan Kaspers to think about this and to help realizing it. Because I know it's really very helpful.
I think that Robert Muir and the UK charity is trying to work out exactly what the building's going to look like and what the costs are. And then once we have that information, we may launch this initiative. Yeah.
I'm sure that Ferry, who you know,
yes,
the chair of Gertjan Kaspers now, he will be interested and also is willing to, to help.
Any other questions? Keith.
Thanks, Gordon. Just building on what you were saying, it seems to me that child cancer is a very emotive issue, and it actually lends itself to actually fundraising on crowdfunding. And it just seems to me that if we use the power of the whole district actually on an initiative to raise funding that might be matched by, as you say, a global or another grant, then that seems to me, and if it was raised, for example, for an MRI machine, then that would actually carry a lot of weight in terms of getting funds raised. So I just raised that in passing. It's certainly an issue for you to maybe think about. Thank you.
Thanks for that, Keith. Gertjan, one question from me. I think you mentioned at one point that the improvement in survival rates with cancer hasn't improved that much recently. But since your training spell at Great Ormond Street Hospital, what has the improvement been in that period of time?
You mean in countries such as UK and the Netherlands?
Well, just in the developed world. In the developed
world, yeah. I guess it went up from something like 70%, 70, to now 76 or 77. So we are improving. We have been improving for a long time period, 1% per year. But of course, the closer you get to the 100%, the more difficult it gets. And we have a couple of very difficult diseases to deal with. So you sometimes read in publications 80% cure, but I think that's mainly when you look at 5-year survival. And to really conclude somebody has been cured, you need longer follow-up. 5 years, not enough. That's also true, for instance, for breast cancer or prostate cancer, and also for many types of childhood cancer, you need a longer follow-up. So 5 years is not enough. We are still improving in developed countries. And in developing countries, it seems that we are improving. But I think if you would include in the calculations the many children that are not diagnosed, and they must all die, because childhood cancer will not be cured from its own or by a witchcraft doctor or whatever, then the progress is very limited. And I can give you the example of this hospital, El Red Malawi, where we have rather strong data now. And when I started working there, we had 90 patients per year. And now, 13 years later, we have 280. But in the surroundings, there must be at least 1,400 children. And that means that, 1,100 of them are not even diagnosed. Yeah. And if you incorporate that in your survival rates, improvements in developing countries are lower than the improvements in the rich countries.
And also, Gertjan, can you maybe explain the importance of palliative care? Because obviously we're not.
Yeah, true. Yeah. I did not put too much emphasis on it, but that's not because it's not important. So, I mean, when children die, but also during treatment, it's really important that they don't suffer as much as they do nowadays. And that is really an important area of care and also of research. And I think it's slowly improving. And if you cannot cure a child, at least make sure that with appropriate palliative care, he or she is not suffering, at least not in an inhumane way. It's difficult to avoid all types of suffering. There's always a little bit of problems and complications or vomiting, but if you focus on it, you can do a lot. And indeed, in for instance, Jogja, we have a palliative care project ongoing, and in all our training programs, palliation, pain, nausea, vomiting, but also fear is discussed, and we try to improve it. Yeah, important aspect.
Thanks so much, Gertjan. Just any more questions before I finish the meeting? No. Right. Could I invite you all to lift your glasses and toast the royal families of the UK and the Netherlands, please?
I ordered one.
Good for you, Gertjan.
Good. This is Dutch. What is it again? Bokbier. So whenever you come to the Netherlands, you must try a bokbier. It's nice.
And also, let's all join together and toast Rotary and peace the world over.
Absolutely.
Peace the world over.
Cheers.
Thank you very much, Gertjan. That was fascinating.
Thank you so much. It was a pleasure.
Yeah, thank you.
Okay. Thank you. Good night.
Bye-bye. Bye-bye.